Thanks for spending some of your Saturday morning with me. I got out of tennis duties this morning, so it's not too bad. So we'll talk about hip and knee osteoarthritis. Might save questions towards the end, but if there's any burning you want clarification through the talk, you can stop. I don't mind. But we talk about about me. I started my journey as a physiotherapist. It's actually one of the other speakers today, Oliver Duncan, and I did physio together, living in Subiaco in our teens. I had medicine and orthopaedic surgery later, and I went to Queensland and did some fellowships in COVID time, and back now at Charlie's in Hollywood and Subiaco now as well. My interests are in direct anterior hip replacement and most surgeries of the knee, most things around the foot and ankle. I thought we'd address some of the common misconceptions about hip and knee osteoarthritis. This often comes up, that the things I hear from patients, replacements lasting 10 years, that you should be in your 70s when you have an operation. Cardiovascular strength and exercise are going to worsen my pain, and that MRI is the best investigation for everything. So I thought we'd sort of just have these thoughts as we go through the talk today. And we'll talk a little bit about knee osteoarthritis and then hip osteoarthritis, and what are the evidence-based interventions that you can do in your practice before someone needs someone like me. How long do these replacements last, and what are the outcomes? Because you hear about knee replacements, 20% of people are unhappy with knee replacements in some studies. So we'll address that, and similar things with hip osteoarthritis, and there's a bit more interest in different approaches for hip. You might get patients asking about those things, and how much does that differ for their outcomes. So this is how I work up knee osteoarthritis. So it starts with a history. The patients have a typical aching type pain. It is normally well centered over the knee. They often have effusions, and then I'll go with an examination. Always examine the hip. There's a whole series of patients having knee interventions for hip pathology. Doesn't work so well. Weight-bearing X-rays are your best investigation. And they should involve these 4 series. So if you take nothing else away, I think this is the most important slide. So an AP, X-ray of the knee, a Rosenberg view. They won't give you that unless you ask for a skyline as well, and then a lateral. And then often you've got your diagnosis. So someone like this, you've got medial compartments almost down to bone on bone. You have your diagnosis. You can work on from there. If they've got reserved joint space, so even this one on the right side of this knee, that's moderate osteoarthritis on the right side. You do a scan, you'll see meniscal tears, but really the diagnosis is more moderate osteoarthritis. A CT arthrogram, but still see quite a bit. It's really hard to make a decision on a patient with meniscal pathology on a CT arthrogram. For me, I really don't take anyone to surgery on that. So I think the only role really for CT arthrograms is if a patient has an incompatible device with an MRI scanner and you want to go that way. Otherwise, weight-bearing X-rays and then an MRI is a better way to work them up. And these are some of those other views you might not see. So skyline view shows lateral patellofemoral osteoarthritis. That seems to be reasonably common. And this is your Rosenberg view. So this would be your standard weight-bearing X-ray that you get. And this is a perfect example of a patient who, in the Rosenberg, which is, that's taken from behind in slight flexion. So you're seeing a different aspect of the femur. And particularly the patients might have a valgus knee, an inward knee. They often only have changes on that Rosenberg view, and the lateral compartment will be really wasted away on that Rosenberg. This is the power of weight bearing. So you can see a non-weight bearing X-ray, same patient. There's a little clue, there's quite a big tibial cyst here. But as soon as you load the patient up and you do weight bearing X-rays, you see that you get your diagnosis again. So always weight bearing for hip and knee, and those 4 views. And this is where, if you go straight to an MRI, you'll get a 1.5-page report about the meniscus and how it's extruded and torn. I mean, this is the same patient. You have your diagnosis on the X-ray. This is their MRI. It's a little bit harder to interpret. And if you haven't got the time to sit there and look through the MRI images, then I think you end up getting confused with the MRI report there. This is a really good resource. The American Academy of Orthopaedic Surgeons every few years review the primary practice interventions for knee arthritis in particular. And so they came out with their last edition in 2022. And so they'll go through all the summary review and put it into a nice 2-page document about all the supplements that are around and the new interventions and whether they work or not. And consistently over the years, the ones that really come out on top are weight loss, exercise, and exercise-based physio, not hands-on based physio. The new one that's getting traction in Perth is the GLAD program. It's one of a few self-management programs that are out there. There's lots of other things that are out there that aren't necessarily supported by people other than Dennis Lilly. But dietary supplementation has some good studies that prove it works in unbiased studies. In particular, turmeric extract and ginger extract have been proven in randomized control trials to help statistically. But unfortunately, the benefit is about this big patient, so it's 1 point on their VAS scale. So if you've got someone that might be important to them, then it's certainly worth a try. Glucosamine chondroitin, well supported in studies that are done by the companies that make money from selling it, and in independent trials, never really shown to be much better than placebo. They don't have a harm other than lightening the purse or the wallet. So you can try it on these patients, but there's even studies done on patients that are on it, swear that they get benefit from it. They've randomized them to either continue or to go to a sugar pill, and blinded the patients, still no difference in those drugs. So I don't tend to use them routinely, but they're very low harm. So if you've got a patient who's really not ready, or you think they're not going to do well with an operation, or mild, you can try these things. I don't have a problem with that. Vitamin D, there are some studies to support that as well. That's probably looking at a subset of population with osteomalacia, so they have low vitamin D, getting some bone pain from that way. I think they'll benefit from vitamin D supplements. Topical non-steroidal, I never thought this was much good, but the Academy think this is actually supported by evidence. So rubbing with the Voltaren or Nurofen gel on the knee, really very limited harm, and with your patient that might not be able to tolerate an oral non-steroidal, this is a good option for them, particularly for the knee. It doesn't really, when people are quite large, they still can access their knee subcutaneously. Braces, it's rare to find a patient who's going to tolerate a brace like this, but this is what they're talking about when they say braces are supported. So this is a particular type of brace which offloads the knee. So you've got this is your typical varus OA. Most people come in with this pattern, so they really cramp down the medial side, and this brace really pushes them over on the lateral side. Here's the X-ray in the brace. It does much like a high tibial osteotomy, one of the operations we can do if they're a bit young. It's just Perth in summer. This is really hard to tolerate for most people. They're reasonably expensive, these braces, but in saying that, a lot of the health insurance companies will give a patient a benefit if the brace is over $100. So sometimes the more expensive braces actually work out to be financially viable for some patients. There's a place called APE in Osborne Park that I tend to send to patients with. They have an orthotist who works there a few times a week. So you can send a patient along and they'll fit them and try them with these braces. That's best if they're varus, as we talked about, when they're more severe. Exercise therapy, this is your biggest benefit for the patients, routinely brought out in studies, no matter how bad the arthritis is. It doesn't matter what they do, but generally they do better when it's low impact exercise. So the pool works well for some people, but even if it's walking, if it's bike, a cross trainer, something like that, it's a bit of a trial and error to see what's going to work in the patient's lifestyle with their disease. But that's probably the best thing that they can do. And even if they don't get out of having an operation altogether, they're much better for having the operation. They've already started some prehabilitation. There's a moderate recommendation for balance agility training. Patients sometimes get this, they may experience a temporary increase in pain. This is when I tend to use injections for these, sometimes to get them over that little hump that they might have when they're trying to do something with strong evidence to support it. There's quite a few physios in town now, and in the public system, Osborne Park Hospital does offer this program regularly through the year. So the GLAD program, it's really a combination of physiotherapy exercises and then some self-management pain programs. So GLAD is out of Denmark. It's a good thing for patients to try. But if they've already done physio exercise and they're walking themselves, they're probably going to get a little more out of this. There's a moderate recommendation for weight loss. It can sometimes be a very difficult thing for patients to do if they've got bad osteoarthritis. So I normally just have a discussion with patients. With bigger patients are still just as happy if they come to surgery as if they're normal body weight, but the risks are higher from surgery. So if they can get their body weight down, one, their pain will be better, but also their surgery is safer if they need it. These are things that often get recommended that have no evidence to support their benefit. In fact, there's evidence to say that they're not any better than just doing placebo treatment. So if you're sending them to the physio and they're doing massage, they're doing ultrasound, that type of thing, that's the wrong physiotherapy for the patient. It's not making them any better. It's a lot more expensive than the dentist, the legal meds. They're better off taking that. Massage doesn't help. Laser, acupuncture, shockwave therapy, TENS. It still gets used quite a lot by physiotherapists, chiropractors. It shouldn't really be used in this environment. Non-steroidals are your best medication for osteoarthritis of the hip and the knee. The ones that I tend to go for are Celebrex, meloxicam, or naproxen being the long-acting anti-inflammatories, so they're going to have the best effect for them. Celebrex has the lowest side effect profile for the gut, so that's the one I tend to go for first, but sometimes people find it doesn't work as well as a Mobic or an naproxen. I just tend to get them to take it on their bad days and not take it every day, but they can have issues. You see more than what I do. Paracetamol in and out of these recommendations over the year, actually whether it helps or not osteoarthritic pain, but there's really minimal side effects with them. So I tend to use it for patients as well. Oral narcotics do not work well for osteoarthritis. They make the operation, if they come to that point, really difficult to control their pain. So someone who's on 100 milligrams of Depentadol, Spiralase 50, having a knee replacement is a nightmare to manage their pain post-operatively. So I would strongly encourage you not to prescribe these medications for the patients. They've been shown not to improve their pain or function, and they increase their adverse effects. So Tramadol is the other one that used to be in this list, has been supported by the Academy. So these things flick in and out of favour. It'll probably be in the next one again. So if you need something else, probably Tramadol has had historically the better support for something in a short term. There's a whole lot more injectables around. Generally, these are short-term benefit for patients. And I don't use them as an ongoing routine thing. I get really nervous about people having repeated injections because it has been shown to increase their infection. And every month or so, someone will turn up in the public hospitals with a hip infection from steroid injections into their hip. They don't work that well, but there are a few incidents I'll use them. So if a patient's got a holiday plan, they're caring for a partner, they're really at the stage where their pain warrants an operation, but they can't have it, that's when I'll use an injection to get them through a period. Or we're going to start a physio program, an exercise based, and they're just not getting going or they're flaring and they're pain. I think that's the perfect time to use an injection. For the knee, there's hyaluronic acid, so your lip filler, it's being used everywhere. So wish I invented that. The numbers needed to treat are 17, so they're pretty high. About $500 is what you can get for patients. There is a radiology provider, IMED, that will do it bulk bill for the patient, but it's a series of 3 injections. I think they just make their money from doing the injection and claiming Medicare. That makes me nervous about having multiple injections for the patient. And it's actually it's a low molecular weight hyaluronic acid, so it's not quite as good as the high molecular weight ones that are available. So I'm not that keen on using that one, but it is a more cost-effective solution for your patients. Steroids really just as good as hyaluronic acid, but you can expect about 3 months relief from these. If you have repeated steroid injections, you can bring on that osteoarthritis a bit faster. The other thing is that I don't do a replacement within 3 months of the steroid injection. So just be mindful about that. If you've got a patient who you really think they're ready for an operation, the injection really just muddies the water with infection risk. PRP, there's a lot of evidence in PRP. You'll find things like most things in medicine, studies to support it, studies to say it's no good. Generally, on a whole, it hasn't got much benefit over the other steroids and hyaluronic acids. I tend to use PRP in tendinopathies, so your Achilles, tendinopathies, things where you worry about steroid injections causing tendon rupture. But even then, the steroid, the evidence is a little bit shaky for PAP. Arthroscopy is not supported when the diagnosis is osteoarthritis. So this is a happy patient. Their cartilage is really good. They've got a nasty tear. It's flicking in and out. They do really well with arthroscopy. I mean, arthroscopy is getting a bit of a bad name because this used to be done a lot. You can see the cartilage surfaces are no good. The diagnosis here is osteoarthritis, whereas this the diagnosis is meniscal tear. So they're completely different patients. And arthroscopy doesn't work well if the arthritis is more than moderate. So my approach for osteoarthritis of the knee, talk about weight loss, they get a supervised exercise program. I don't mind if that's a physio, chiro, exercise physiologist, but the physios tend to be accessible and they get a rebate from public health. We talk about embrace, most patients don't go for it. Make sure they're taking non-steroidals, Panadol when they have flare-ups. If they're not ready for an operation, so they've got more moderate osteoarthritis, or I think they're going to do poorly with an operation, then a supplement or injection to get them going for their exercise-based therapy. But that's really where I use that. Surgery, we talked about arthroscopy, that's only if they don't have arthritis or they have a root tear, which sometimes diagnosed. An osteotomy works well for younger patients. And then there's different types of knee replacements. So this is an osteotomy. So this is the best patient for this is a 40-year-old manual labourer who really is a poor candidate for an arthroplasty. And they've got one-sided disease. So you can get 10, 15 years out of this type of joint in a patient that really wants to run or they want to do manually active work. That's a patient who is going to threaten the longevity of their knee replacement. So these are the type of things we have available for them. So how long does it last? Here, 10 years. That's really not borne out. In Australia, we have one of the best joint registries in the world. So every knee replacement, every hip replacement, shoulder and ankle now that goes in Australia and for the last 20 years is recorded. And if that comes out, then that's flagged and then we know how long these things last. For the last edition of this, published every year, we also have happy outcome scores, so happiness scores with them. So 36,000 knee replacements done every year. This is a powerful piece of evidence. So these are all comers. So at 20 years, 92% of knee replacements still in the patient functioning well. So the 10-year survival rate of all knees is 95%. So really the 10-year sort of common misconception of lasting these knee replacements isn't borne out by a really powerful piece of evidence there. The other thing to say about this is the plastic in knee replacements changed about 12 years ago to a better type of plastic, and in every mark we have up until that stage, it's outperforming the old plastic. So these 20-year, 15-year numbers, that's on the old plastic. The new numbers should be even better than this. So that's really encouraging. For knees, this changes quite a bit with what age you are. So there is an age where a knee replacement is not a good idea. Generally, less than 50, it's not a good idea to have a knee replacement. Sometimes there are exceptions because these are the age. So these are under 55-year-old patients. They just demand more. They do more. They try and run. They're active all the time. So they may rattle that loose, and they may wear out the bearing in the knee. But even still, at 20 years, their revision rate approaching 20%. If you're over 55, then you're really about 15%. So 85% of those knee replacements still doing well at 20 years if you're over 55. And the older you go, the better that lasts. So there's still good numbers for someone who might be in otherwise a miserable place in their life, and they want to have their best years when they get over 55. So I often see people wanting to have a knee replacement year before they retire, recover during their sick leave, and then go caravanning. This is the new information we're getting out. So it's 6 months after a knee replacement. And I think for knee replacements, there's still a percentage of people that are struggling along with their rehab at 6 months. Not that many anymore, but they'll still improve. So at 6 months, the percentage of people that are worse, a little bit or much worse is about 4%. So happiness rate above 90%. And I think if you did this at 12 months, you'll see a lot of these ones are about the same coming into the happiness rate, and some of the little better going over is much better. So that 20% of patients unhappy with knee replacements, that's in small studies where they might have 100 patients, they check their study. This is 36,000 patients. So that's 1 year that we've started doing it in Australia. But New Zealand's been doing it for about 10 years. They have similar numbers. So, the satisfaction rate for a knee replacement is over 90%. And the longevity is normally, if they're over 55, pretty good out to 20 years and counting. So it's a good operation. And if you've got a patient that is a good candidate, then don't hold back from it. The slide I don't have in there is when's the time for a knee replacement. So for me, their X-ray needs to be bad enough. So if they've got an X-ray that shows both sides are a bit like this, and they have typical arthritic pain, then that's just not a good candidate for a knee replacement. So they need to have advanced osteoarthritis on imaging, and then they need to have pain. Because sometimes you see the patients and they have this, they don't have any pain, they don't need a knee replacement. Nothing bad's going to happen to them, they're not going to miss a window of operation. So generally when they can't walk very far, or they're woken at night by the pain, or they start falling, so they're not trusting their leg, and their radiology shows that they've got bad arthritis, they're the candidates for knee replacements. It's good. So hip, thankfully hip's a bit similar. Again, though, it's a weight-bearing X-ray to start. So here's your diagnosis. That's bone on bone. It's severe hip arthritis. This is actually probably even severe hip arthritis as well. And hip, thankfully, is a little bit easier joint. And it's well, I've got some graphics in this one. So the main one of confusion with the hip is what's the source of the pain. And if you broadly think about trochanteric source of pain and then in the hip source of pain. So trochanteric, typically the patients at night, they hate sleeping on their side, they get a burning pain down the thigh. It's right here, they point to it, it's on the surface. And when you examine them, you can touch it and they'll be sore around the trochanter. So that's your bursitis. Most of the time it's not bursitis, it's the tendon of the gluteus medius or minimus. It's got some tears or some tendinopathy, and then the bursa gets inflamed over the top. So that's a big percentage of patients who have trochanteric pain. And then if they've got intra-articular hip pathology, number one is in the groin. They complain it's deep ache in here. They can't quite touch it. It's deep in the buttock, or it's down on the inside of their thigh down to their knee. And they're the three most common sort of presentations of hip joint pathology. So always have that one in the back of your mind. To examine the hip, it's really a range of motion. If they've got hip arthritis, they're going to be really stiff. So they might come in and say, I can't put my shoes on anymore. Sometimes the hips have got severe arthritis. They don't have a lot of pain. They just can't do things anymore. Can't get the shoes on, can't bend down, can't pick things up off the ground. So that's not an uncommon presentation with hip pathology as well. Whereas the trochanteric source is really lying on it, or from the classic one, 50 and upwards year old who walks down the stops, and you see them Trendelenburg gating like this. They've got a full glute med tear. So that one's a good diagnosis to make at Coles or Woolworths. So work out weight bearing AP pelvis, lateral hip X-ray, easy done. The weight bearing, it's probably shown up still with non-weight bearing on hip X-rays. It's not as important as the knees, but I still request it. It gives us more information. If you really think they have hip osteoarthritis as well, just write template on the view, and they'll put this little ball on there. Probably half the surgeons in Perth will use that to gauge the size and plan their hip replacement. The patient doesn't have to have another X-ray if they need it. Hip, in terms of conservative, so sort of non-surgical treatment options, if they've got an X-ray like this, there's nothing that's going to work for that patient other than a hip replacement. Whereas if it's more mild or moderate, they may get benefits. It's not as powerful as in the knee arthritis, where the patients can really do well with non-surgical treatment. Someone like this is never going to avoid a hip replacement for any meaningful length of time. But the things that have been studied and by the same body, this American Academy, injections, it's only corticosteroid for hips. Hyaluronic acid hasn't been shown to be helpful over placebo. But again, it's really short-term relief. So these patients don't quite do as well with the exercise therapy as what knees do. The knees are really susceptible to quads wasting and weakness. So the patients do well with strengthening. With the hip, they just don't do so well with strengthening. So that the injection use is much smaller in my practice for hips than it is for knees. That's the same analgesia options, though. You don't have to learn anything new from knees. It's non-steroidal, Panadol. Avoid the opioids. Physiotherapy, it's supported if they have mild or moderate osteoarthritis, but it's not supported in hip if they've got severe osteoarthritis. I still don't think you lose anything from that, other than it can be expensive. But if they're going to do it, it's low impact aerobic strengthening exercises again. Glucosamine again, no benefit over placebo for these patients. So that's it really. It's a lot smaller for hip arthritis, unfortunately. But the good news is the replacements are better than in knees, and it's an easier rehabilitation for a patient. If you have a knee replacement patient, they need to be an active participant in their rehab. They need to do their strengthening. In the hips, if they do nothing for you, they'll still be happy with that operation. So hip, again, we're seeing 20 years longevity out to 92%. So these are good. That's the old plastic again. I think you'll see that this number will come down quite a lot for hips. But it's hard to make that too much better. When we come to the age, it has less impact on this, so less worried about younger patients. There are patients at Perth Children's Hospital that have hip replacements in their teenage years, some severe kid hip diseases, and there's no other options for us. So you see less than 20-year-olds have hip replacements. So yeah, I'm much less worried about having a 40-year-old with severe hip arthritis having a hip replacement. And that's sort of brought out these numbers where we saw in knees was upwards about 18% in the under 55s. In the hips, it's not too dissimilar to the older patients for these. So you can be more reliable in the outcome for a younger patient for a hip replacement. What improvements will I get? Well, again, it's a good operation. So this is their VAS scores, the Oxford hip scores, the Oxford hip and knee scores we use. Over 40 is approaching normal. 20 is terrible function. They do well. It doesn't matter if they're male, female, what age there is. This is probably the best thing, asking the patients how were they. So much worse or a little worse, it's less than 2%. These patients routinely do well. I think with hips, the improvement is much quicker. So knee replacements, I don't think patients like me much until about week 4 after their operation. Then they're about a bit better than what they were before the operation. Hip replacements, often they wake up the next day after the operation, they're already better. So these are carpal tunnels and hip replacements. I could just do that all day. I'd be very happy. My clinic would be easy. So these patients do well. Approaches, so there's different approaches for hip replacements, and this is sort of changing around Australia. Traditionally, we're a very English-based orthopaedic surgeon. Professor David Wood, who's retired, brought out all of his English fellows and kept them all here after they did their fellowship. So we have a lot of English surgeons who traditionally order the posterior approach. On mainland Europe for years, they've been doing the anterior approach. And we have Marcus Kuster here who sort of taught quite a few of us through our training. So some of us do the anterior approach now. What's the difference? Probably in the long run, once you get 6 months after the operation, there's no difference for those patients in most of the studies. In the first 3 to 6 months, the patients from the front will get up faster, they'll have less pain, they get going quicker, but in the long term, really the risk of needing another operation for any reason is the same, whether you do it from the back, front or side, and their happiness is the same. So it's still a good operation no matter how you do it. But there are some differences and some risks and complications that are unique to each patient. So this is a traditional posterior approach. We split the glute max in the line of the fibers. These are the short, so piriformis and gemelli. They come off the femur, so we cut those off. We do the hip replacement through this, and then we sew them back on afterwards. Those tendons of bone healing takes 3 to 6 months, and that's probably the difference in these patients compared to doing it from the front. If you've got a really tricky hip to do, this is the safest way to do it. If you fracture the femur down here, this is the safest way to do it. So, and if it's a really obese patient, then this is the way I do it. The other way that I do most of my hip replacements is from the front. So this is an anterior approach. That's tensor fasciae lata here, sartorius. So make a cut over here, and we squeeze down through the muscles. Don't cut any muscles, so they get up, you're going a bit quicker. If you've got a thin patient, they really benefit from that operation early on. But after that time, long term, the studies suggest that these patients do much similar. think the strength of this is we can do X-ray, so I'll know that the leg length is the same or about the same within what the patient can feel before the patient leaves the table. So that's why I really like it, because I know how everything's sitting before the patient leaves the operation, and I can change it if we need to. That's the main things I thought about talking about, but happy to ask any questions about lower limb orthopedics or upper limb if you've got it, and I'll do my best.
In terms of the long-term follow-up of, say, knee replacements,
yep.
You said there's 90% success rate in 20 years.
Yes.
Do you wait till the patients actually get problems, or do you still follow them up with periodic X-rays?
So I X-ray them at 1 year, and then I don't do it after that. But I write a letter back to yourselves asking you for a 5-yearly X-ray of those joint replacements. It's pretty low yield, to be honest. Most patients are going to present with a problem, but there are some patients who will pick up that are starting to wear out their bearing, and they might be easily addressed with quite a simple revision of that bearing surface. So it's just there's a lot of patients to follow to pick those ones that don't come in that commonly. But yeah, so I do an X-ray at 1 year, and then I tend to follow them up. But I recommend every 5 years they have an X-ray for hip and knee.
And you mentioned that you shouldn't give steroids within 3 months of surgery.
Yes.
What about imidonides? Would that be acceptable?
Yeah, that's probably okay. Although it's probably the instrumentation of the hip joint that carries most of the risk. The steroid has a potent anti-inflammatory, also probably an anti or autoimmune type of suppression as well. So it's probably worse with a steroid, but yeah, I'd be nervous about hyaluronic acid as well. If you think they're ready for the operation, then they should have the operation. If you think they're not a good candidate yet for the operation, that's when they would do well with an injection and something else like physio exercise. So I think they're different patients. So I'd try not to use it in the patients you think that they need an operation.
Hi, with anterior and posterior approaches, the different types of hip replacements you can use, like it doesn't alter if someone wants to have more range of movement or something like that, that's not important.
Not so important, no. So an anterior approach has a lower risk of dislocation. So I let patients do whatever they want. They can sleep on it. They can sit on low chairs. There's not the same, put on a cushion, don't cross your legs. They can do whatever they want. So they have a lower dislocation rate.
Sometimes you get people coming saying they want an anterior one,
yeah,
because they do yoga or something.
Yeah, I think that's probably a good indication. Yeah, so a horse rider or a yoga or someone like that who's really going to test the boundaries. I've had a couple referred to me from my colleagues who do posterior approach with neuromuscular disorders, so Charcot-Marie-Tooth, things like that, where they really get funny pelvic positions.
And like the lower risk of dislocation in the short term.
That's for the life. That's for the life of that. Yeah, there is a higher fracture rate. So with the anterior approach, so that's if you want to be eaten by a tiger or a lion. So the end result's pretty similar, but it depends on where the patient's risk is. So if they're a yoga, they're a hypermobile type of person, then yeah, their risk is dislocation, or they're alcoholic or some other thing that's going to make them fall and be really risk of dislocation. That's a good patient. Mostly it's the same hip replacement, but surgeons who tend to do posterior approaches will tend to use the dual mobility. You might hear that. So that's sort of a ball and then another ball in the hip to try and get around the higher risk of dislocation.
With the hyaluronic acid, simply can affect usually flexion, duration of effectiveness. Which one is better, or how much duration we expect with that type of hyaluronic acid?
Yeah, so there's the two. So yeah, singles are the two high molecular weight ones that are readily available. They're very comparable. It just depends on which company's brief you read. I don't have a preference for either of those two, but they're the two that I would use. There's some radiology providers around that stock it and have it there, so it's a one-stop shop for the patient. Otherwise, you can send them to the chemist, they pick it up, and then they take it to Perth RAD or SKG, and I'll put them in for them.
So my question is, does Simvic last longer than the Flexa?
Yes, yeah, than that one. The other one's a low molecular weight. Yeah, so yeah, I think the Simvisc or Durolane, if you're going to use them, yeah. But three months is kind of the average. You'll get patients who say 2 years later I'm better, but it's probably because the exercise therapy has taken over. Yeah.
So overall, if I send my patients to you, private patients are not a problem, but public patients, we are talking about catchment areas. And you tell me that my patients are from the south of where you are from this side. So if patients see you in your room,
Yeah.
afterwards, if it is public, do you put them on the public specific area or?
It's a tricky ethical question because if that patient gets referred to my public clinic at Osborne Park or Sir Charles Gardner, then they often wait 2 years to get that appointment. Whereas you can come and see me in Hollywood at my rooms in 2 weeks' time for those patients. So that patient is jumping ahead of patients that have waited 2 years. So I got sure. Yeah.
It says some orthopedic surgeons, don't accept, depending on where they operate. So if they're happy to pay you, you see them in the private.
Yeah.
But they don't have a private insurance cover.
Yeah.
You normally put them on the, public hospital list afterwards, or how you?
I would only do that if they have a real problem hip. So say they're a young person still working, can't work, unemployed, getting to needing opioids. And I think that needs to be addressed faster, or they have a dissolved hip, so an avascular necrosis, something that's going to make the hip replacement really bad or really difficult in the longer term, then I will do that. But otherwise, I feel bad for the patients that have waited their time in the public queue to get their appointment. So really, they probably should get a referral to both places, and they get an opinion when they pay their money and come to a private. If they really need urgent because of a clinical indication, then I don't mind doing that. But otherwise, I feel uneasy about putting them on the public wait room. And the hospitals will not take it if it's out of boundary.
Thank you. There's just a question up in the chat as well.
So the patella doesn't get removed, but it gets resurfaced depending on the surgeon. So knee surgeons feel differently about the sort of the influence of pain from the patellofemoral joint. Most of the studies suggest that patients are generally happier in the long term if you resurface everyone's patella, and we're poor judges of saying who has pain from that and who doesn't. So I resurface everyone's, but you might have some complications from that.
Hi, thanks for that. I've got a couple of patients who have done really well with knee osteoarthritis with the steroid injections.
Yep.
And they get a prolonged period of relief from it, maybe due to the exercise,
Yes.
exercise more.
Yep.
But they might come back, once a year wanting another injection.
Yep.
Given that they get such a good response from it, but it has potential to accelerate OA, what's your approach with that? And is there kind of a maximum number of steroid injections?
Yeah, I think I think you will accelerate it. So if they're getting 5 injections over 5 years, I don't think that's a good treatment regime for a patient. If they're not a good candidate, so that they're mild arthritis on their X-ray, then I'd be nervous about their response to an operation, so that you might push the boundaries on those type of patients. But if they're close, they're bone on bone, and you really think that they're going to be needing an operation at some stage, and they're old, they're sort of above 55, then I'll probably bite the bullet and get the operation done. They should be happy, but I'd be nervous about every year doing it. But yeah, if you get 2 years and then that comes back, then I would do it again. Patient. Yes. Yeah, absolutely. Yeah, and the SKJ and PRC have a bit of a bidding war on MRI. So for every orthopaedic specialist I've spoken to, they now bulk bill all our MRI. So if you've got a patient where you think they want an MRI, they don't want to pay for it, and then weight-bearing X-rays and the referral, I look at every referral that comes through, and if they need an MRI before they come, that's organised by the room. So yeah, don't feel like you have to put them to a couple $100 out of pocket. In the same way, if you just want advice and you think, I'm happy to get a text. How do I get that? or, what do you think about this patient? Do they need it? And then we can, if they're being some way involved in the patient, I'm happy to write an MRI referral for that patient so they don't have to pay for it. And then we can, talk about what they need, if they need to come or they don't need to come. So that's my mobile on there if you want to ask me like that.
Brilliant. Is that it?